Okay, so you may say that inflammation just seems like this horrible thing. Inflammation is terrible because it kills your cells, it causes vasodilation, it makes the pimple develop, it causes keratin retention, all these terrible things that basically make acne happen. Let's just stop the inflammation. Well, first off, how do you do that? Well, the best known one that we got so far, as far as I know, is hydrocortisone. So basically, hydrocortisone creams basically are steroidal anti-inflammatories that work. We're not really exactly sure how they work, but as far as skin applications, but one of the best ways is that they cause vasoconstriction. Now, systemically, basically orally, prednisone and stuff, you may have taken that for, let's say, poison ivy, and they're fairly effective. At least for me, it's tremendously effective at reducing the development of more bubbles on my skin. So, and that's because prednisone or hydrocortisone, cortisol, there's like 3 different names. I know. I'm sorry. Basically stops the majority, if not almost, seems like every known pathway to inflammation. So why don't we just put cortisol over our face? Well, there's a number of reasons. One of them is basically it without any sort of bloodstream or blood supply, and also with the actual chemical interacting with these with the keratin sites, with the skin cells, you basically get degradation of the skin cells, and you also can get sebum production. So it's weird that this anti-inflammatory can actually cause a lot of inflammatory-like results as far as acne is concerned. And so let's say maybe also you've gotten like a really big cyst on your head. The doctor said, well, we can give him a shot of cortisol. So that stops the really big cyst, but it may result in future acne, which is why they don't recommend, lathering yourself up with the thing that they just injected your face with, which seemed to work so well for your cyst. So, again, the other thing that is really weird is that it causes a compensatory release of nitric oxide. So basically, this vasoconstriction that goes on, maybe because you're blocking the release of nitric oxide, which is a strong vasodilator, but you're not stopping the production within the cell. So basically what you get is that these cells start filling with nitric oxide, and then once push comes to shove, once the floodgates open, say you stop or it just gets you've used it too long, basically this nitric oxide begins to flush out into the bloodstream, and then you get a lot of vasodilation. So this is really interesting and sort of gets into the component that it could actually cause dependency or sort of like an addiction to the chemical. And as I see it, a dependency, or sort of the worst thing that can happen with a topical medication, or any medication really, is that it feels good to do, but basically causes a deterioration of the condition. So let's say your skin is really itchy and irritated. You put the hydrocortisone cream on it, and it gets less irritated and itchy. But the result is that you keep needing this cream, this hydrocortisone cream, to reduce the itchiness. But you're never going to you're never going to get away from the itchiness because it's actually causing it. So basically, you need to go through this itchy period to recover from the use of this hydrocortisone. It's a really slippery slope, and it's it's really evil, to be honest. And which is one of the reasons why I don't suggest we use hydrocortisone cream in the majority of any case. Potentially, as they do currently, use them in severe nodular or cystic acne. So this kind of gets back to my point of vitamin, or I should say antioxidants and oxidants sort of logic to treating acne. So one of the things that happens when you're intaking vitamin C is it actually forms into hydrogen peroxide, which is a very strong oxidative compound, so or free radical compound. And this is what's been suggested to be beneficial for both cancer and potentially in the case of acne, along with vitamin C's direct benefits of effectiveness. But so this is just, I guess, what I'm trying to suggest is that we need to take everything into consideration when we're considering something like an antioxidant versus oxidant approach. That's just not the logic that needed to be brought in. That's not to say that vitamin C or something like that doesn't work, but again, when you're trying to press upon the idea that you need more of this, or you're not getting enough of this, or you just need to take 600 times the normal dose or what have you, it should be understood how it works and what may be another method that can be used adjunctively with this to enhance its effectiveness, or just even take another target delivery system, therapeutic target, and then hopefully get some benefit that way. It's not, we can't just sit there and just throw vitamin C at an issue and expect it to go away with not that much, consideration for everything that occurs within the body. So now one thought might be, glutathione? I didn't know glutathione was the principal antioxidant. How do I get more glutathione? Well, here's what's funny, is that if you're looking to really get some more glutathione, you may need B12, and you may also need B6. Now let's say maybe ramping up B12 and ramping up B6 helps your development of glutathione. I don't know if we talked about it quite yet, but I'll tell you right now that B6 and B12 are not necessarily, especially in high doses, the best thing for acne. There is, many people have had reactions to B12 injections, which basically broke them out immensely. And as we'll see, B6 as a prelude is not good for P. acne, or I should say is very good for P. acne, and we'll see why in a moment. So here's a good example of an approach that sort of works within the linear thinking and the binary thinking of oxidants versus antioxidants in the acne. Now remember, I want to say that you shouldn't take an exclusive approach to acne as this antioxidants versus oxidants. However, it's not to say that something can't be learned from categorizing things, and it's also not something that can be learned, that should be ignored or not learned from. I think, as we see here, with protein oxidation and lipid oxidation increasing, so these are molecules that are oxidized, increasing, we see a severity increase. So clear skin versus mild skin versus moderate skin versus severe skin. We have a clearly defined progression of oxidation and an increase in the severity of acne. Here with glutathione and superoxide dismutase, we see a decline in these. These are antioxidants. Many people have heard of glutathione. Fewer people have heard of superoxide dismutase. Now, this is, I would say, a pretty good comparison to what we should consider when we're looking at acne. It's something that shows a pretty clear correlation. I want to be careful here because, like I've said, you don't want to be, oh, that's up, that's down, use more of that. It can work that way, and I think what we should consider is using these approaches, but we shouldn't be entirely reliant. It's sort of like considering, oh, there's a war going on in some unknown area. Let's send one troop to go fight the war. It doesn't make any sense. You don't just send one person to go help out an entire war. You would send your army. You would send a variety of different, you send the Navy, you send the Army, you send the Air Force. It's about trying to treat the issue at multiple different levels. So could potentially applying these glutathione and superoxide dismutase directly to the skin be helpful? Yes, but also so does dietary approaches and sleep and such that we'll get into later. So I guess what I want to say is that I'm acknowledging this, and that I hope that you're now more aware of how this can potentially work and how this system hopes to extract some of the best data and apply it to curing your acne. So basically what an antioxidant is, if you have ever wondered it, is a chemical or atom that basically has more electrons than it needs. Basically, it can donate one electron from its electron valence to a free radical. So basically, these free radicals, they really want these electrons. They steal the electrons. And what can happen when you steal electrons, you can cause changes in the structure of atoms and molecules. Again, these are what hold the molecules together. This is a principle of chemistry. So, antioxidants could be good for basically stopping the active damage of free radicals. That's really, as it is, the most basic understanding of antioxidants versus oxidants. But I mean, when you break the whole body down to this one aspect, you're going to see there's a lot of differences, and not everything matches up. In other words, not necessarily the best antioxidants are necessarily the best things for your body. So again, the BHT and BHA are good antioxidants, but they may not necessarily be something you should just be, having for cereal every day. So again, this sort of basically showcases what's going on. You have free radicals setting off a chain of membrane damage. You get erosion of the cell, and then basically you say that antioxidants stop this cell erosion and damage, and none of this actually ends up happening. Again, we should really be careful about trying to break down something as complex as acne into this just very basic role, but having a comprehension of it can definitely help us in an understanding of a more complex outlook towards acne. Open comedones are yet another variable opposed to papules, pustules, nodules, or cysts. These are what many speculate to be oxygenated areas of the skin, and what I speculate to be a predisposition for inelasticity in the skin. So if you have this, you would likely have maybe sun-damaged skin, or skin that is just not very elastic. So as a similar beast to this, something that we can compare it to are solar comedones and Farber-Rochet syndrome. The solar comedones are comedones caused by excessive sun exposure, in theory, and Farber-Rochet syndrome is the a more severe sort of case of long-term exposure to and aging to sun and again aging. So, and it seems to begin with the inelasticity of the skin, meaning that the skin is it doesn't snap back. It's leathery in nature. So when something goes up to try and push the skin, from the pore, the skin simply seems to give way more regularly. It doesn't have as much tension in the pore, and as a result, more of the material gets exposed to oxygen and sunlight. So just like you tan, you could also be tanning your pimple, and you could also be exposing it to oxygen. So that's the two theories, for the most part, is that this is excessive melanin and excessive oxygenation. I believe they're leaning more to the melanin theory. Now, one possibility that you could do as an experiment is you could actually take a pustule, remove it from your skin, expose it to sunlight, see what happens. Does it blacken, or does it remain basically a white tinge? The other element is that you could try and expose it to excessive levels of oxygen and see what occurs. Now, this is outside. This is not a perfect model for the skin, clearly, but it may be a way of figuring out what are the leading causes. And you could also do a third experiment along with your control, of course, that you could basically use a certain level of both elements and see if that gets you a more a darkened element. The other really important is that there is the white tail at the end of the end of a pimple, or sorry, the end of a blackhead. So this white tail indicates that not the entirety of that blackhead is in fact black. So there has to be some element of some sort of exposure from the exterior environment that is causing it to become blackened. And I think it's the inelasticity, which allows more interaction with the exterior environment, both sunlight and oxygen, that creates the blackened appearance. And again, if you have something that causes you to have inelasticity of your skin, and you do something that exposes you to sunlight and or excessive amounts of oxygen, then maybe you may be predispositioned to have this occurrence. I've heard, but this is completely anecdotal, that certain people who have never had blackheads before, when they use something like a isotretinoin or retin-A, actually experience blackheads, and that may be because of the tretinoin's ability to sort of dry the skin and sort of reduce some of its elasticity. And even though it can moment shrink your pores. It's a weird sort of it shrinks the pores because it acts on the sebaceous gland, but it may also cause a less inelasticity as it's shrinking the pores. So even though you have less elasticity because you have less pressure on the pore because you have a smaller sebaceous gland, it may actually shrink. That is anecdotal in theory, but these are sort of challenges that we need to face. So one thing is you have this diagraph over here of exactly how melanin is produced, and there's also different kind of melanin. Some variants are more blackened, and some are more brownish or sort of that tan nature. That is sort of a Hispanic versus African American sort of descent. There's different variants of melanin that are being secreted, and some of these may become oxygenated as well, and that's what's causing it. So it's a sort of, it's difficult to say whether or not what is specifically going on here, but we have some comparisons, and hopefully this gives us better insight into how we can address blackheads in the future. But we do know that there is a significant correlation between your general pimple and the blackheads that occur. These don't occur necessarily completely independent of each other. They can quite frequently co-occur, meaning that if you have acne, you may have a few pimples, but you may also have a couple blackheads. Personally, I don't really experience blackheads. That may be because I have younger skin. But that said, it's not to say that someone who is in 14 or 16 doesn't get blackheads. They may actually do get blackheads. So clearly, there's other elements that we need to diagnose and treat. But hopefully, this gives you again some direction as far as what you can pursue intellectually and experimentally in order to deduce the best way to address something like a blackhead. So one distinction I want to make before we get too involved is the distinction between blackheads and sebaceous filaments. Sebaceous filaments are not blackheads. That's what you see on the nose, where they generally are most predominant or most notable, but they occur largely throughout the whole body. It's just because of the structure and the thinness of the skin, suggestively, they are more notable. So as you can see, that you would maybe think that this guy has, or person I should say, has blackheads, but it really is just I know it really isn't blackheads. It looks so much like it, then how can you not call it that? Well, the reason why you can't really call it blackheads is because, I mean, these are found in everybody, and they do appear to have a functional role. Like hairs, they help move sebum onto the skin and don't allow it to get stuck there. This is basically, it's weird because it's like it's like what are called follicular casts, but they basically are more composed of sebum, and they, I mean, if you remove them, they're replaced within 30 days. And the other thing is, look, you can only really see them when you're dead on point with the person in front of you, and staring directly at their nose. only those sort of ovular mirrors are going to give you any sort of magnification that's going to allow you to actually see these things. They're not harming you. They're probably helping you, as I've said before, with its ability to move sebum onto the skin. So just let them be. Don't squeeze them. Don't try and remove them. Don't use any sort of peels on them. Just let them sit. You should ask your dermatologist about them, but I think the biggest distinction is the fact that these are tiny, 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 tiny. Like not 1 millimeter. These things are super tiny. Basically the size of your pore. So there's no sort of dilation or anything going on. So they're really not obstructing your appearance, I would say. If you really feel terrible about them, opposed to removing them, I may even say try and mask them with something. But just, yeah, let them chill. Alright. So unfortunately, the histology that I've been able to find has been, in my mind, insufficient to basically replicate this. As far as this is reputably similar to a blackhead here. So that's definitely a blackhead. Has a dilated orifice. It's very open. It's filled with keratin. So this is this. This is likely this here. So this is sort of what's been hard to find is something that really gives this sort of distinction. Allows sebum to basically come up a little bit and sort of dilates the skin and sort of closes off still the orifice. So I haven't been able to really find a good histology of that, a good or any sort of picturesque view of what has been generally known as the open comedone or closed comedone. So if someone can direct me to where I can find something more like that, that'd be perfect. But for now, I believe that this gives you the best distinction. Maybe my eyes are just not set for comprehending this minute differences in histology, but basically here is where you would probably suggest, so this part here is probably this here. So this is where we're sort of pinching off, and this is where it's sort of leaking out. And this is where everything's starting to get clogged up and gunked up, and not allowing it to come up. And this is why things are getting red. The follicular wall was starting to rupture a little bit or leak, and so you're going to get neutrophil penetration and all sorts of things going on in there. So it's probably the microcomedone, or the papule, I should say, or pustule is a more accurate term because it's actually coming to a head. But so that should hopefully give you some understanding of, again, the histology, what we're dealing with, and the differences between blackheads and whiteheads. We're still sort of on the topic of UV rays and damage and things that basically can contribute to acne. I want to take a moment to acknowledge skin burn pathology, or sunburn pathology, I should say. Not a chemical burn, but actually a UV ray induced burn. How that happens? Well, there's a number of things that go on, and this could be non-coding microRNA, protein glycylation, altered drugs. That's a an antibiotic or a retinoid or a BP, and it could also be like monohydroperoxide. Um, this is basically an immune reaction, and I say it isn't a chemical burn, but in fact, the body is responding to not necessarily the UV radiation, but the changes that the UV radiation has induced in the body. So the chemicals that have been produced that make the sunburn hurt and can also contribute to sort of sun poisoning. So why you may feel so horrible after getting a big sunburn, like Will Ferrell here. um, but it's important to have some sort of distinction here between sunburn pathology and photodermatitis. Although they're very similar, and I did sort of mold them together. But when you get a chemical, let's say you get an antibiotic, and it can be it's a photosensitizer. Basically, what that means is that when this drug enters your system and eventually goes to your skin, when the sun hits it, it causes changes within the drug that your body's responding to, and this is basically causing the itchiness or the redness that would otherwise not be there. It could make you extraordinarily sensitive to the skin, or to the sun, I should say. What's weird here again is that elderly don't get sunburns as regularly as younger people do, let's say 18-year-old or so. And some may say that's a good thing because sunburns are associated with cancer. Like the worse sunburn you get, the more cancer you're likely to get in your older age. However, it may be some sort of protective mechanism that the sunburn's having. So, although it's definitely bad that you're getting a bunch of UV radiation, if you didn't have that sunburn, then it would be even worse because the cells that your inflammation, or whatever you want to call it, is killing off, they would still be around and they'd be able to proliferate and potentially become carcinogenic earlier than they do when you grow up, basically, or get into your elderly age, or unfortunately even sooner. So that's basically what I want to talk about with that, is that I think what's most interesting about everything that I've just said is the fact that elderly people don't get sunburns as regularly, and that they also have a reduction in sebum, and therefore they're more UV receptive, I guess you could say. They're not protected as well, and still they don't get their burns as regularly. So that's weird. All right. I hope you understand that we're still staying on topic. This is going to get brought up again later as treatments for acne and the synergism between UV radiation and the drug. So this is just a quick bit. Remember what I was talking about earlier. There's plenty of melanocytes within the sebaceous follicle. They don't necessarily have all of the same characteristics, but it goes to show you that there's still potential. I mean, some of these melanosomes or melanocytes are there to basically make hairs black. So you make yourself have a terminal hair or something like that, and so that's what gives that its color. Others are there for natural skin reasons, and maybe others are there for another reason that also is causing the blackheads to be black, also causing this eumelanin. This is the melanocyte transfer from, or melanosome transfer. This is a melanocyte that's transferring melanosomes which is the chemical, really, or a vesicle that holds the chemical, and transferring that into the keratinocytes, which is the skin cells. So again, melanocyte is the thing that makes melanin. Melanosome is the thing that holds the melanin, and the melanosome goes into the skin cell and ends up changing the color. And it could be going into the follicular casts or the dead skin cells that are in your pore and causing it to slowly become blackened. So that's and this is just a quick bit about UV radiation and how you could look at it from a cellular stress perspective. And here is a fairly important aspect of basically how the skin grows up, if you want to say that. It's, you have your basal layer, you have your stratum spinosum, stratum granulosum, and stratum corneum. This is your dead skin cells, if you will. So I think we've gotten into this before, but this is a pretty big lecture, and I'm doing it in bits and pieces, so I'm not really sure exactly what I have given you. But basically, this ends up getting thin in acne patients, but when you actually have this, which dips down and makes the pore, this could basically becoming thick, and then you're also getting all of the sebaceous follicles rupturing and getting into there, and so you have this mixture that makes up the pustule, or I guess the follicular casts, however you want to say it, the dead skin cells, the clog. But yeah, so they age, they thin, and then that becomes basically the top layer of your skin, or in this case a pustule. We'll get more into this aspect when we're talking about the skin barrier. So the skin barrier, this is the acid mantle, the microflora, the skin cells, and the water. That's basically everything that is the skin is acting as a sort of external barrier, what divides you, or at least your muscle cells, or your fat cells, I should say, from the outside world. Now, the thing, as we piece this together, is the acid mantle is very important, and a lot of people talk about it religiously, like, oh, you gotta have, you're acid protected, and you have to make sure that you got the right pH and all this other stuff, when they really don't understand what the acid mantle even is. It largely is lipids and amino acids, yet they think that it is just acid, I think. That's what it sounds like. I feel like they don't understand even what is making the acid mantle acidic, and that is these lipids and amino acids. Because if it was just acid, it would just be your H3O, because this is definitively what we define as an acid, as acid, basically. So anything that can donate this proton and form H3O plus is going to be an acid. Or actually at least have some acidic capacity. Now, microflora, again, we'll get into, but that's basically all the skin bacteria and how that regulates your body. And the skin cells, we just talked about that a little bit, and basically how things are how the skin cells are structured together is something we're going to be talking about, and a variety of other things. And then obviously your water, which basically keeps everything hydrated and working properly. So let's move on. So this slide is mainly to showcase this graph here. Basically, a lot of people like to say that you have to keep your face at or your acid mantle at a 5.0 range or 5.5, when in reality, especially if you're going to try and showcase the skin as a general, both from your face to your back, there's a obvious fluctuation person to person, and even a person's everyday activities, like if you've exercised, or if you're running, or if you just showered. These things can impact your skin pH, so trying to identify the most optimal pH can be difficult. However, people who have a more acidic pH, so on the lower end, seem to be better off than people on the upper range of the pH scale. So basically, not using soap would probably be your best option. I wouldn't necessarily go too crazy and suggest that you need to start putting hydrogen chloride on your skin, although that can be done in certain instances, or maybe not that, but certain acids are put on the skin that are at very high ranges, but we'll discuss that later. So one thing as well, though, that you want to look at is the fact that the focus of this sort of pH concept is that P. acne doesn't grow in these conditions. If your pH is just right, the bacteria dies and or doesn't grow and doesn't cause any issue. That's really not how it works. It doesn't seem that the P. acne really minds too much any sort of acidity within the normal range of our skin. It's a commensal bacteria. It's a bacteria that has been designed evolutionary to stick within our range. And so anything that really goes above or below our range is probably something that's going to damage our own skin. Again, like I said, you may be better off sticking slightly acidic, but I mean, the best thing you're going to do from at least a complete face treatment is you're going to maybe, from this perspective, is you're going to maybe put like a vitamin C on your skin. Not like a crazy high concentration, but and there's some evidence to suggest in certain populations of bacteria that this actually works better than your strong acids within certain ranges, because the bacteria actually doesn't completely throw out all of the hydrogen chloride, or sorry, protons, and as a result, it can build up. So these weak acids have a structural difference that allows them to build up within the bacteria, whereas the strong acids don't have that component, and therefore they're better dealt with and they have less impact. So with the weak acids, them building up because of their structural difference, end up killing off the bacteria a bit more. So that's pretty interesting, but really not necessary to know. So quickly, natural moisturizing factor is basically your proteins that come from the bursting of cells as they come to the surface of your skin. So we'll talk a little bit more again about that in the next slide, I believe. And there's lipids there. Aging is an important aspect because we see a reduction in the obvious. We see a reduction in the acid mantle as a result of drying of aged skin, because the sebaceous glands don't seem to be as active, and then therefore we can get changes within the acid mantle that may have an impact on the health and, again, the permeability of the skin. That's really a pretty critical component, is that this acid mantle affects permeability of the skin, which can impact disease and potentially acne. So yes, here is the natural moisturizing factor composition. Now, I think there's an element of variability, as there is with any individual, when you're talking about something like as general as what makes up something. Um, I don't know of any differences per se in people who have acne versus people who don't in natural moisturizing factor. However, I do know here that it's suggested that 40% of natural moisturizing factor is composed of free amino acids, basically leucine, isoleucine, basic molecules of proteins. And then you get into a variety of other different sorts of compounds and also some salts. So something else to consider is that natural moisturizing factor, as its term suggests, is designed to keep in moisture. Um, so it attempts to do that, but if things get a little too wet, let's say you're taking a long shower or something like that, you may just basically remove all of the water that you've tried to preserve in the skin. So it's this sort of an issue of a little bit more, a little bit more, a little bit more, too much, and it's all gone. So when you're talking about trying to keep in moisture, you're talking about trying to keep in water. You're talking about natural moisturizing factor. You're also talking about, though, the importance that basically for a skin barrier, the importance that it doesn't come up out of the lower levels of the skin. Although you want to keep what's called the stratum corneum hydrated, you also want to keep the rest of the skin hydrated, because that's what's going to keep it healthy. If it all just gets sucked up right to the stratum corneum, basically everything else is going to dry out. So the body is designed as sort of waterproofing lipid system within those more distal, more deeper layers, and then still with this sort of natural moisturizing factor in lighter quantities. So basically that tries to keep things moist but not too moist, and sort of uses both lipids and water as this sort of aqueous medium, which it can transmit molecules and sort of interact with itself and stay healthy. So that basically covers natural moisturizing factor from a quick standpoint. Again, this will be a recurring element in future slides. So now that we're beginning to like moisturization, and maybe thinking about how exactly sebum reacts with bacteria in order to produce something that can cause a pimple. Well, looking at what sebum is composed of, we can see that there's waxy esters, which are composed about 26% of it, squalene, which is about 12%, triglycerides, 41%, some of which, so 4.5 of which is cholesterol, free fatty acids, about 16%, and fat metabolites. So we'll see when we analyze the changes that occur for someone who's healthy, their sebum count, and then someone who has acne, and see their sebum differences. There's a lot of variability within how these things are measured, because whether or not you can measure it specifically from the fluid sac, if you measure it after it's been on top of the skin, and those elements are causing some controversy within the scientific community. However, the analyzation that I've done for you tries to draw the best conclusion that science can offer us on this. One thing I will offer is the fact that there are, from anything else that is secreted from the body, what makes sebum specifically unique is the fact that waxy esters are produced and squalene are produced. These are something that that aren't found in other areas of secretions, and this is maybe why acne comes about, or is manifests as a point with, or manifests with such good correlation with acne. So basically, this squalene may be doing, or in waxy esters may be doing something to coagulate, coagulate bacteria, along with the keratinocytes, and then also basically causing those bacteria to grow. Hopefully, if you develop some way of hindering the metabolism of the bacteria among trying to open up these waxy esters to not have this coagulation effect, along with a number of other things, we may be able to get a result from the sebum perspective. We can also see whether or not a oil will cause a breakout, possibly by analyzing the triglyceride or the fatty acid components, and see if, well, if coconut oil is better versus olive oil, or if you should be worried about any of them at all. I think a lot of people have valid concerns whenever they consider a moisturizer, if it's going to make them break out, because it's going to quote-unquote clog their pores. Well, I wouldn't necessarily say that oil is going to be going in exclusively and clogging them up, but it may be a reaction that it's having with your skin that may be clogging it up. You could also consider the fact that if you're allergic to soybean, and you put soybean oil all over your face, that you might have an issue there. So that's basically what I wanted to say about sebum, and what I want you to begin to question about the perspective of moisturization, and why acne may have a specific gravitation towards sebum. So, what is the function of sebum? I mean, it's here, and is its function just to make us get acne? Like, why is sebum here? Sebum may be used to transport vitamin E. It may also be used as a additive lubrication and hydration agent, and also add to create osmotic regulation. Basically, if that whole aspect of leaking out too much water as a result of a lack of a good lipid layer to repel the water from getting out, basically. Or I should say getting in. So you don't want too much water in the lipid area of your skin, because you basically cause osmotic stress. You basically what ends up happening is, you have a concentration gradient, and things move out of the cell that shouldn't move out of the cell, and you stress the cell out because it's trying to hold on to all of its good stuff. And it's like, oh my god, all this water is causing me to freak out. So that's why you need this sebum, potentially, because it helps with this osmotic regulation. There is certainly components to the innate immune system, within the sebum, and potentially its understanding of tolerance to microbial organisms. One element of acne that isn't discussed so much is the function of sebum secretion could be affecting acne. Um, so there are different types of glands. There's a myocrine gland, there's apocrine glands, and there's holocrine glands, all of them which have different types of secretion. So myocrine glands basically secrete substance. So they secrete, maybe, let's say, an oil or bile, digestive enzymes maybe, and this can be found in the pancreas. Now there are also apocrine glands. They actually secrete bits and pieces of the membrane, so they'll get pinched off, and then that membrane of the cell will actually go into the medium and then be transported out of the gland. That occurs in the mammary gland. Now with holocrine glands, there's actually complete disintegration of cells. So whole cells are basically breaking off, going into the liquid medium, and then being transported and excreted out. And they're basically going through mitosis and dividing within the gland. And this sort of complete this sort of complete excretion is a very destructive and a form of secretion, and could be owing to why sebaceous glands are more likely to clog opposed to other glands. Not to say that apocrine glands don't get clogged, because mastitis is certainly something that occurs in females. So now let's move on. So here are a couple histology pictures of the hair follicle. Now here you can see you have pretty large lobes on this sebaceous gland, and here you have the actual lobe of the sebaceous gland looked at a little bit closer, and you can see that as these cells move up, they end up dying off and breaking apart, like I showed you in the last video. Now, here you actually have a fairly small sebaceous gland that's connected to this hair follicle, and really the main reason why I'm showing you, three different histology pictures of the sebaceous gland is the sebaceous gland / the hair follicle, is because the more images you'll see, the more familiarized you get. If I show you one image of let's say the hair follicle, you're going to think that everything looks like that, and when you see something that doesn't, that you're not, you don't understand where things are organized, you're gonna get thrown off. So hopefully by showcasing the variability within the differences of different hair follicle, or different particular hair follicles, you're going to be able to understand how maybe your condition could vary, or what is really going on. You're going to get familiarized with it. I mean, particularly, like I said, with images. If you have, the more information that you have as far as how many images you've seen, the easier it is going to be to get acclimated into what you're seeing, as far as where's the sebaceous gland, where's the hair follicle, what's going on over here, and that may help your pathogenic understanding of acne. So now let's move on to this image, which isn't a histology image. This is just a rendering. So you may notice something different about this rendering, in that it's got this thing attached to it. So what is this thing? This is an apocrine gland. This is a gland that is actually implicated in acne inversa. So my talk has been primarily about acne vulgaris, and it will continue to be, but I think noting certain differences in why people get certain different conditions is important. And here it may seem that acne inversa is related to the infection of the apocrine gland. Now, along those lines, you'll see something different here. Now, this is actually a sweat gland, and you'll see that milia is more so associated with the infection of a sweat gland than it is with the infection of a the sebaceous gland. So, about 70 or 78%, according to one study, suggests that 78% of milia is caused by infection of the sweat gland. The other, 20% or so is the hair follicle or the sebaceous gland, and just kind of random variations in the skin, actually, which is weird. But so that hopefully gives you an understanding. Oh, I also want to say one of the reasons why milia needs to be lanced is because look at this tiny hole. There's nothing coming up out of that compared to this. And if you notice that, if something gets stuck there and something starts, stretching out the skin, that's going to close up in a hurry. So that's the reason why milia usually needs to be lanced. It's because this is just impossible to open up, or I would pop, if you will. So that basically sums up what I want to speak about here. Let's move on. When it comes to lipogenesis, the formation of fats within the sebaceous gland, or really anywhere actually, in the body, in the human body, it begins with SREBP1 and SREBP2. These have lines that result in triglycerides and phospholipids along with cholesterols. These result in things like squalene, again, triglycerides, and free fatty acids. All of those stem from this cell line. Now you might say, well, if you want to reduce, let's say, something like squalene, you block a certain enzyme. Although that's possible, you're also considering the repercussions throughout the body. If you're going to try and make it oral, that probably won't be the best idea. If you want to try and make it oral, that may help, but you also suffer whatever the loss is of losing squalene, along with potentially not being fully effective. I mean, there's usually some sort of backup system that picks up any sort of blockage. So if you're going to block enzyme, let's say, for instance, enzyme A, enzyme B will come along and start, or pathway B will come along and start still secreting some squalene, or producing squalene, I should say. Now, I'm giving this information to you so maybe you can have some understanding of what you may want to consider when you're thinking about your face and overproduction of sebum, maybe as a result of insulin or inflammation. Those components. How might histamine alter these pathways or these routes in order to produce or increase the activity in a specific area? Maybe something like histamine doesn't necessarily increase the gene activity of any one of those of the two I spoke of, one or two, but actually increases a different enzyme that helps speed up the process regardless of the gene expression. Again, that's all sort of a philosophical note. How much bearing this may have on us, I'm not sure as far as its impact on acne. So here we have another example of the layers of the skin: the stratum corneum, stratum luteum, stratum granulosum, stratum spinosum, and stratum basale. Um, so there's a couple important things to talk about. One is sort of the dry skin aspect. So if you have dry skin, one of the things that's occurring is that you have basically cells that are stuck together that are flaking off that are also not hydrated. Um, so to talk about that, we have to go from the bottom up. So that's the basement membrane is what everything's attached to, and it's attached by these hemidemosomes. Um, these are basically proteins that are able to adhere to molecules by actually entering in the filament or entering in the cell, or the different cells, I should say. And here we have the desmosomes, which are basically cell-cell contact, where this is cell membrane, this is cell-cell. So hemidemosomes, membrane cell, desmosomes, cell-cell. So as these cells move up the epidermis, we see, or the dermis, the epidermis, you're going to be able to see certain changes. One of those is that these, in the stratum spinosum, is that you have an increase in lipids. In the stratum granulosum, you have these granular molecules, or basically bits being formed, and that these are going to actually help sort of bounce around and break up parts of the cell and allow those cell contents to sort of spill into the rest of the matrix. And this helps hydrate everything. And so as you're coming up, you're going to see sort of this these hydrations and this sort of these lipids sort of form. Now, as you're moving up, you're sort of slowly removing some of these desmosomes, and then they end up becoming maybe only one or none attached and end up flaking off. The problem is when these desmosomes don't get released, and you end up with a lot of flakes clumped together, and then that ends up being a very apparent release of keratinocytes. The other thing is when these are being released, you could suggest a little too early, because the problem is that there isn't enough hydration to keep those cells that shouldn't divide or shouldn't be released yet together, and because there's no hydration sort of helping them adhere together, stick, rather than via cohesion, and as a result they flake off in these broken clumps. That basically sums up the majority of what I wanted to talk about here. This is an element I find very interesting, because whenever you're talking about maybe the sensitivity of skin, you may want to consider how thick of a skin it has, or you have in that specific area. So maybe someone with thin skin has skin that is very sensitive, and as we can see in this other the graph to our right, as we become older, our skin overall actually becomes thicker. And as we can see on our left, there are specific areas that have specific thicknesses in their skin. Now, it doesn't seem to be a very high determining factor as far as the presentation of acne, because in all areas with maybe fairly equal element of presentation, acne is still present. It doesn't depend upon, as you can see, the neck is a 1.5, roughly speaking, on average of the population, and it doesn't mean that people constantly break out on their neck. However, as a man, I do know that my neck is far more likely to have razor burn as a result of shaving, and that may have be somewhat influenced not only by the way I shave, but also my and razor, but also by the skin thickness. So this may also alter exactly how you wipe your face. So opposed to being more aggressive, you may be lighter in areas that are less thick, and that may give you an advantage as far as how to treat your skin. So intercellular junctions. We've talked about a couple different types of intercellular junctions. One of them was desmosomes and hemidesmosomes. But there's also three other types, at least, which are gap junctions, adherent junctions, and tight junctions. As you see here, they're made up of different types of protein complexes. But mainly what I wanted to discuss is the potential role of these in future research of acne, which may be something like why like the role of gap junctions in requesting, if you will, immune cells to come in and sort of inflame the pore, or maybe something like sensitivity of the skin in the lack of desmosomes or permeability of tight junctions. These can have a role not only just in the epidermis, but also, as we've heard with leaky gut syndrome, potentially in the gut as well. So this is less of a direct, this is how this relates to acne, and more of an open-ended sort of discussion of what we can look at further with acne research. But certainly with desmosomes and their adhesion capacity play a functional role in the development of a plug in the pore. So that's certainly something to consider when you're trying to do some maybe research of your own. So this gives you some idea of what forms some of the intercellular junctions, adhesion junctions, desmosomes, and hemidesmosomes, and how basically the desmosomes and hemidesmosomes differ. But I'm not going to go into all the details of it. That's something maybe you would like to go ahead and do in your own research. But right now we're not gonna go too deep into that. Here is also some of the processes that occur and the chemicals that are related to it, with cornification and stratum corneum formation, along with desquamination, which is basically the removal of the corneodesmosomes, if you will, if not desmosomes. So that gives you some bearing to understand what's occurring. Again, this is another diagram that showcases how these processes occur and may give you a better understanding of what's going on. So here we have the corneodesmosomes, which is basically a corneocyte, or the most superficial layer, the dead skin cell, if you will, that is also adhered together through these corneodesmosomes. Really, there's not a great deal of difference between desmosomes and corneodesmosomes, but something to be considered of the wording of how they're said, especially when you're researching. So there's the cornified envelope, envelope lipids, and natural moisturizing factor that's within it. Cornified in general just sort of means dead in this case, but it's not really dead. There's still a lot of activity that's going on within these corneocytes. I want to also point out the stratum corneum and how it basically breaks apart, more so than anything, how the desmosomes, or corneodesmosomes, excuse me, break apart. And they break apart through these proteolytic enzymes. We'll get a little bit more specific when we're talking about drugs, but one thing that occurs with salicylic acid is that it breaks apart these corneodesmosomes along with isotretinoin. You're kind of combating two evils. One is dry skin or flaky skin, and the other is clogged pores. So trying to balance out breaking up the corneocytes and not breaking up the skin is a sort of battle, and we'll talk about how you can do that specifically with certain pharmaceuticals and moisturizers and such in a little bit later when we talk about therapies. You see this labeled as KLK targets. This kind of gets back to the vasodilations and bradykinin sort of genre of compounds that form, but basically it's proteolytic enzymes, if you want to give it a general name, that are breaking apart these cells. So this is an example of IL, interleukin, or I think a lot of people would argue immune perspective on the epidermal barrier, and it's basically how the epidermis layers are developing. So you have keratin synthesis, keratin proliferation, desmosomes, and you can see you have things that decrease, IL-31, and then things that increase here, IL-36, so IL-6, IL-19, IL-20, IL-21, so on and so forth. And again, it's moving up, and you also see here with the desmosome maturation that goes down, and you can just see these arrows, and then the subsequent IL number is what's changing as it moves through the layers of the skin. Again, a note is IL-4 and IL-13 are increased in desquamination. So maybe if we could input those into the pore, that's just facetious talk, but maybe you could get a breaking up of the skin in that particular area. That's targeted therapies, and we'll talk about that later. So now that we've sort of beat to death this concept of skin layers and connection, there's also one other aspect. We talked about lipids, but one thing we didn't talk about is water. So water is a very essential part of the epidermal barrier, and how that water sort of migrates through the epidermal layers is very important as well. As you can see, it's very well hydrated on its the basal layer, and as it moves upward, it gets less and less hydrated. However, this is where you see your dry skin presentation. Now, water moves through the epidermal layers via a number of ways. Your osmosis and your general capacity for water to migrate. But another one that it's actually actively facilitated by is aquaporons. These actually help move water out of the membrane and into the cell, and vice versa. Again, glycerol here actually helps the migration of water into the epidermal layers. So when you have that glycerol there, you can actually help facilitate water migration and help the gradient to better hydrate the skin cells and the layers around the skin. So by bringing water from basically the lowest area up to the upper layers. This is a very important aspect about the skin that isn't talked a whole lot about yet, so hopefully this will help bring to light some of the importance that it has. The other thing to consider is that there's enzymes that are in your skin that are hydro-specific, meaning that they need water in order to operate. When water is put on the skin or in the area is hydrated, these proteolytic enzymes can actually go into, I wouldn't want to say overdrive, but they start working, and that can help create dry skin, along with the whole aspect that it washes layers of fat away. However, it can also help basically add a degree of plasticity to the skin, maybe helping remove comedones and a number of other things. But the so that is another aspect about hydration of the skin, is that you need the right pH, you need the right hydration, you need a whole variety of aspects to the skin that is necessary for the whole homeostatic processes to continue to operate with a degree of normalcy. If you have too much variations in this, you're going to be putting undue stress, and it's not going to be beneficial. So we'll talk a little bit maybe about more about we're going to be talking about when we go back into this. This is all just building a reference for you. We're going to be talking more about this when we talk about therapies and treatments.